So welcome to the Lord Ramsbothom Memorial Lecture. My name's Nathan Hughes and I'm Professor of Adolescent Health and Justice at the University of Sheffield. But more importantly today, I'm the co-chair of the ABI Justice Network that's hosting today's session. So I'm sure if you're in this room, then the connection between acquired brain injury and criminalisation doesn't need to be kind of laid out to you. We've had a number of systematic reviews that estimate that anywhere from 40 to 55% of people in our prison systems have some diagnosable traumatic brain injury, and other studies suggest rates that might be even higher. So we know that experiences of ABI prior to entering our criminal justice systems and on our journeys through it are incredibly common. So the life trajectories and the pathways from that acquired brain injury through to forms of behaviour that might become criminalised, and even more so to how our systems then recognise and deal with the consequences, the needs, the vulnerabilities that might arise from that brain injury, demand our attention. And so in today's lecture, Tom McMillan will address many of the complexities of those trajectories and offer us his insights as to how our systems can work better to address them. I'll introduce Tom properly in a moment. I wanted to first though just say something about our justice network. So this lecture, as I said, is hosted by the UK Acquired Brain Injury Forum's ABI Justice Network, and the lecture is in honour of its founding chair, the Lord General David Ramsbothom MBE, who again I'll come to in a moment. So the ABI Justice Network was formed in 2011, initially as the Criminal Justice and Acquired Brain Injury Group. It's now chaired by myself and Andy MacDonald MP, and has some kind of 75 members, which include a whole range of people from specialist neuropsychologists and neuropsychiatrists and other professionals, representatives of government departments and key kind of health and justice agencies, professionals that work in various parts of our criminal justice systems, and representatives of kind of charities and groups that work directly with people with ABI. And last and most definitely least, academics like you and I that engage in it. So we hold quarterly meetings, generally to present on research or kind of innovations in practice, but equally to provide kind of networking opportunities to think about how we can work better together, to identify opportunities to have the kind of impact on policy and practice that we're seeking to have. I should say that our mission's changed a little bit over those years. I think to start off with, it was very much about recognition of those prevalence levels that I've talked about. I think you can see from our priorities there that conversation has shifted somewhat, and we're now really concerned with how we get evidence of effective practice into our systems to inform policy, to inform practice, how we make sure that the training that our professionals are receiving is adequate, how the complexities of those needs and those pathways that I talked about are understood. So I would say if that's a mission that you share, we would very much welcome you into our network. You're very welcome to attend our meetings. The email address doesn't show up particularly well there, but grab us afterwards and we can connect you to the network. A few words then on Lord Ramsbothom. So the fact that we're able to reflect as a group on a real step change in how policy and practice recognises brain injury in the UK and is at least seeking to do something about it is very much down to the work of Lord General David Ramsbothom MBE. So Lord Ramsbothom, or David as he would always have us refer to him, was co-chair of the group with Hugh Williams from its inception in 2011 until shortly before his death in late 2022. David was quite remarkable. His life is the sort of life that you would make a mini-series out of on Netflix. On another day, we'll be telling you about his military career, how he rose to the rank of Adjutant General of his service in Northern Ireland and Borneo, among other places, and the many awards he won for that service, culminating in the Knight Grand Cross of the Order of the Bath. But it's his second career that brought him to our attention. So when he left the army, he was made Chief Inspector of prisons for the UK, a role he played from 1995 to 2001, and a role he played with real passion. First going after Michael Howard, our Conservative Home Secretary at the time, for his boot camps approach, then for a series of very high profile and highly critical prison inspections reports, the tone of which were really damning, not just the institutions, but to the systems that allowed those institutions to behave like that, with talk of rottenness and evil and a totally deliberate and unnecessary impoverishment of children. And perhaps most controversially, and I think that's probably his undoing in that role, the argument that he made at the time, completely against the political grain, to to release the killers of Jamie Bolger before they reached adult life and to allow them to lead that life. So ultimately, that political stance kind of removed him from that kind of role, but it definitely didn't stop him. He just found new ways to influence things. So he became the chair of the all-party parliamentary group on penal affairs. He was a very vocal member of the House of Lords, and he became a real advocate and champion for vulnerability in our criminal justice systems, including for people with brain injury, as we came to know him. And what an advocate he was. So, you know, any time spent with David was a new strategy or revision of your failing strategy. He knew exactly who we should talk to, and not only that, but he opened the doors to those conversations as well. And you will remember various meetings with various ministers that David had set up. I think he was a very difficult person to say no to. And he rose above those kind of the party political things that others might find difficult to break down. He wouldn't let any kind of party politics get in the way of any of the things he wanted to achieve. And yeah, was far better in the role for that. So we learned an awful lot from him, how to approach that, only a fraction of which we've been able to put into practice since without his kind of leadership and guidance. And so this lecture is just one of the small ways in which we want to honour him. So we seek to do so by doing what I think he'd have us want to do, by thinking about how we bring robust research to the lives of people who have the potential to do something about it, to do something with it. And so that's the flavour of the kind of conversations that we hope to have today. We're hoping it will inspire those of you who know about brain injury to see the ways in which your knowledge can help us to impact upon the journeys through criminal justice systems that many people experience. Which is why we've invited Tom to give the lecture today. Tom is very well placed to do this. He's the kind of academic that David would have has had a lot of time for. So he combines the kind of robust and innovative research that he does with a real sense of the practical benefit of that. So the benefits for neurorehabilitation, the benefits for evidence-based interventions, the benefits for informing how people think on a daily basis about the work that they're doing, and the benefits for supporting policymakers to think differently about what they're doing. So he's led a series of groundbreaking studies, none of which I'll talk about because I don't want to steal any of his slides, but that have included a long strand on processes of criminalisation of prisons in particular. And this stellar career has seen him receive multiple lifetime achievement or distinguished career awards, including from the Division of Neuropsychology, the International Neuropsychology Society, and the British Psychological Society. I'm delighted, therefore, to invite Tom to come up and open our session today. Tom.
So thanks very much, Nathan, for that introduction, and thank you to UKBIF and Ibia for inviting me to talk today. I just want to talk, first of all, very briefly to you, just really to introduce the session to you. And you'll all be aware of the crisis that we have in prisons in the UK at the moment. You will remember not very long ago, there was a significant issue of running out of places in prisons and an early release scheme put into place to help with that. But these issues are long-standing. And for example, Her Majesty's Inspectorate of Prisons in Scotland, noting overcrowding, social isolation, ageing prisons, access to purposeful and rehabilitative activity, access to consistent healthcare remaining highly problematic. So we're going back 4 or 5 years now, and important issues around the use of imprisonment, including expanding investment in community justice services, reforms to bail and release law, a greater focus on supporting rehabilitation and reintegration. So that last paragraph could have been published last month rather than 5 years ago. I'm not really sure we'll get very much further on. And just to give a little bit further context for you, there are 93,000 people in prison in UK and Northern Ireland. England and Wales have a very high rate of imprisonment. It's amongst the highest rate in Northern and Western Europe. And the costs, the economic costs are very high. Something like 10 to 14 billion pounds a year. They're costing 40 to 50,000 pounds a year to have somebody in prison, and double that for a younger person. Reconviction rates are high. 3 in 10 people returning to custody within a year. highest reconviction rates are in younger people. Violence against the person is the commonest category of crime. Apart from the economic costs, there are obviously huge social costs for everybody involved, really. So the issue that we're wanting to approach today is whether head injury has a role in criminal behaviour. If so, what is the role and what can we do about it? And I want to talk to you about a perspective that I have on a wave of multiple morbidity. As people involved in the justice system are disproportionately coming from deprived and challenging backgrounds. We want to tell you a bit about those backgrounds, ways in which their lives are challenging, and ways in which this is then reflected in this multiple health morbidity that we have, and looking to see whether head injury is a part of that. This is a synopsis of what we're going to work through in this session. We're going to talk about the life challenges, health and crime, theory of criminal behaviour, head injury and crime, prevalence of head injury, characteristics and causes, and how they differ from the general population, multimorbidity and disability. We're then going to look at practical issues, assessment, management, education, and the way forward. And I'll have a slant in that towards younger people, given the focus of the conference. So let's begin at the beginning and look at early challenges in life that can have a lasting impact on brain development and functioning. And so I'm delighted to introduce Liam Doris, who will be known to, I'm sure, all of you. He's a paediatric clinical neuropsychologist working here in Glasgow and is an honorary professor at the University of Glasgow. So Liam's going to talk to us about early challenges in the brain.
Okay, thanks. Yep, so thanks for asking me to share this session, Tom, and I guess this reflects conversations we've been having in recent years. Like many of us, I've been aware of the increasing interest in terms of the role of a traumatic brain injury and offending, particularly violent offending. And over time, I've kind of wondered whether the risk is actually that confers the outcome of offending behaviour is actually about the index TBI, or is it about things that happen beforehand? And I want to explore that. And the things I'm going to talk about are developmental toxicities on one hand, and exposure to non-optimal environments on the other hand. And whether these things create a likelihood, increase your risk of developing things like ADHD, or other behavioural cognitive traits that might make you more impulsive, for example. And just to think about, well, is TBI, is that where the risk starts, or is TBI something that just comes along in the pathway? And we'll look at the kind of more common issues around exposures to developmental toxicities. So there's been a few large-scale population level studies looking at, for example, perinatal events as a predictor of involvement in violent and non-violent crime. And this is a Swedish study. And here they found that exposure to just one perinatal risk factor increases your chance of being convicted of a violent crime by 10%, 11% for men and 9% for women. But in contrast, if you had exposure to 4 adverse events, then the risk goes up to about 30% for men. And what you see here, we're looking at low birth weight and prematurity, but well, what are the causes? You know, if you're born prematurely with low birth weight, there's been a cause for that. And that's what I want to look at. So what are these perinatal events that can lead to these risks? So what do I mean by these terms? Some of you will be very familiar, others maybe less so, but developmental toxicities then are structural or functional alterations that will interfere with development or behaviour. And really, it's exposure to identifiable environmental toxins. So these could be illicit substances like exposure to drugs or alcohol or tobacco in the womb. There could be viral infections. There could be prescribed medications, so things like valproate, metabolic causes, and then exposures that we talk about a bit more often these days, like particular plastic particles. So those are physical biochemical exposures which can alter structural or functional aspects of brain development. And then we've got the early adversity. So let's just say you've not got those toxicities, but you're growing up in poverty. You have access to an adequate diet. We know that nutrition is really important, particularly in the early years of brain development. Have you been exposed to significant physical or sexual abuse? You live in a family high on discord. Particularly exposure to domestic violence is very harmful to development. Living with people who abuse drugs and alcohol, living with someone who's gone to prison, lack of education. And we sometimes talk about these things as adverse childhood experiences or ACEs. But these things are very common in the incarcerated population. And this is data about the reason for referral to the Child Protection Register in Scotland in 2016, so one year. And I imagine this will be similar in different jurisdictions, but if you've got a parent who abuses drugs and alcohol, you're basically going to have all of those other risk factors, so domestic abuse, emotional abuse, neglect, mental health problems, etc., etc. And these are very common problems, particularly in areas high in deprivation. So basically, in case you've not got a good developmental knowledge about brain development, basically the earlier in pregnancy that you're exposed to a toxin, the more chance you have of having a structural abnormality. And if the exposure is later, then you might have a structurally normal brain, but you might have pathological changes that could impact on things like your chances of developing ADHD or another neurodevelopmental problem. And actually, a lot of the problems that we see in adult mental health clinics might have their origins in terms of developmental toxicity effects. So I want to show you a study that just illustrates the point about environment here. So this is our group has done a population level study of every child with newly diagnosed epilepsy in Scotland under 3, a genetic testing. And so this is Greater Glasgow, and the red, so here's what we call the Scottish Index of Multiple Deprivation, which shows the level of deprivation. So red is the bottom decile. You see there's a lot of areas high in deprivation. And at the top, these are the quintiles by deprivation. And here, this one shows the incidence in quintile with a genetic diagnosis. The bottom one is where there's no genetic diagnosis. So we don't have a cause for your epilepsy, you're just generating seizures. And here we see twice the incidence of seizures in the lowest quintile compared to the top, more than twice. So we know that so what's causing that then? And we also know that if your brain can generate seizures, you're more likely to develop cognitive problems and you're more likely to develop neurodevelopmental endpoints too. So in the group, without the genetic diagnosis, we found that there was if the mother smoked during pregnancy, there was twice the chance of febrile seizures. And also if the mother drank, there was also twice the likelihood of having seizures. And again, think about seizures as a marker for a brain that's not developing optimally. I want to just say at this point that I'm talking a lot about the choices that people make, and I do so from a position of compassion and concern. I think, people who live in significant deprivation and challenge, have a lot to deal with, and I don't want to sound at all like I'm making judgments, but I think we also need to notice epidemiologically about what the exposures are quite common in the community. I'm going to skip over ADHD because you'll know what that is. But going back to just drive home some of these points, smoking during pregnancy is really common. So the Royal College of Physicians and Paediatricians and Child Health recently published a report showing that the incidence of smoking during pregnancy ranged from 11 to 17%, with higher rates for younger women living in high areas of high deprivation. So that's a common exposure still, and that puts your risk of ADHD at ×3. Alcohol exposure also is a big problem in the UK. A recent UK prevalence study using meconium analysis, so that's where you can kind of get a very good biomarker for alcohol use during pregnancy, found 42% exposure rates in all live births, with 15% exposed to very high levels of alcohol. It's 15%. Okay, I'll skip along a wee bit. Okay, sorry, I thought I had a wee bit longer, but okay, it's difficult to study the effects of individual drugs because often young women who are using substances when they're pregnant will use various substances, so it's quite hard to study them in isolation. But my take home from that is that from the animal models, if you've been exposed to things like cocaine in utero, you're more likely to engage in impulsive behaviour. So it probably increases your chances of smoking and drinking problematically later in life. So I'll skip that one. I think, so this slide, we published a study a few years ago looking at the development of empathy across the lifespan with a very large sample. And the interesting finding here is this dip here in adolescence. So this is the 13 to 18-year-olds. We see that there's a dip in cognitive empathy. Now, empathy you might think of as one of the more advanced cognitive skills that we have. And for some reason, it kind of goes a bit offline during adolescence. So I think the timing of a brain injury is important here because we've already got the normal dip in empathy. And then if you have an acquired insult at that stage, it's probably going to have a differential impact than if you acquired it later on. So I definitely think there is clearly something about a brain injury that confers more risk. You know, there's cognitive problems, there's affect problems. But I guess my contention is that exposure to developmental toxicities is quite common in our communities. And I think these can be quite fundamental in how they alter the matrix of development, increase your risk of having neurodevelopmental endpoints like ADHD and other things. And actually, there's a lot of risk there. So I think as we move forward, it's important to think about, well, how much is the TBI the real risk factor versus something that happens to young people who are probably a bit more impulsive, maybe a bit higher in ADHD traits, and the risk was far earlier. And a lot of this stuff is modifiable. It's difficult. We need to have some strategy and leadership around public health, universal education. But I think there's a lot more we could do in terms of brain health at an earlier stage. So if we can just kind of bear that in mind as we think about, is a TBI the risk factor, or did the risk come before the index TBI?
Thank you, Liam. So, okay, I'm not sure if this is on. We have time for a couple of comments or questions for Liam before we hand over to Tom, if anyone has any. No pressure. Otherwise, go on, Hugh.
Yeah, fantastic. Thank you, Liam. And really great, not necessarily like some good luck on life poisoning. Criminal violent crime, criminal student population, they 2.8% of the signaling. So there's take account of we need to that microanalysis, there's Facebook saying that earlier about the day how to dealing with and bring different depends on what kind of way is it or I guess we need to look for
Yeah, absolutely. So, we've got very powerful bodies in this country that have not really strong universal public health messages that make signal across the world. That's kind of maybe I think we've got a problem in society that needs to be addressed. Not blame but have learned the ability to make choices. Think about how we approach as a society.
Excellent. Okay, we'll hand over to Tom.
So thanks very much, Liam. That's very useful first step in our going through our plan for the session today. And this isn't meant to be an all-encompassing slide, but we're beginning to think about the life challenges that are likely that the people who are involved in the criminal justice system are likely to be exposed to. We can think about these early life factors that Liam has told us about. We can think about social and physical environment, poverty, housing, and so on, that people are exposed to. We can think about health behaviours that can be more common in people coming from lower socioeconomic groups. And we can think about trauma. We can think about emotional trauma, and we can think about physical trauma. When we think about physical trauma, we will want to be thinking about head injury. So if we just briefly think about environmental challenges. In Glasgow, there has been an industrial decline over a long period of time. There certainly was poverty and deprivation in Victorian times, but around the 1960s, there was significant industrial decline, which led to unemployment and poor housing. There's a picture there of housing in Glasgow in the 1960s. Looks like people are living in derelict houses. The housing has improved to an extent, but with the industrial decline came social and geographical isolation and lack of social mobility. And the geographical isolation partly linked to the kind of tribal gang culture in Glasgow and in other Victorian cities in the UK, where it was dangerous for young people to move, to just simply be in an adjacent district or area because they'd be threatened and subject to violence. And so with these life challenges comes poor diet, smoking, alcohol abuse, drug use, and environmental challenges. And in the top right corner there, you'll see a deep fried Mars bar. Characteristic of the diet, people think, in Glasgow. To be honest, I've never seen one. But there's an icon, really, for people having foods which are high in fat, high in carbohydrates, and salt. And with this comes a series of health hazards and a decline in health in Scotland and in Glasgow since the 1980s. Scotland remains currently the drug, Glasgow, the drug capital for Europe. In fact, Scotland has the highest rate of drug deaths in Europe. And with deprivation, there's an association with crime. So if you look here at rankings of socioeconomic deprivation and link that to the proportion of people in prison in Scotland, you'll see that disproportionately the highest proportion is there coming from the lowest deprived group. And that being fairly consistent over a period here of a decade. We see there's really not been much change across that time period. So we have deprivation, we have life challenges, and we have crime being associated with deprivation. Now, if we begin to think about head injury now, what do theories of crime tell us about head injury? Would head injury and what we know about it fit in with those theories? Well, in fact, they would. A dominant theory, a dominant social theory of crime is a general theory of crime by Gottfried and Hirschi. And for over three decades, this has been a dominant theory. And it's particularly relevant to the effects of head injury because it focuses on self-control. And as you know, self-control can be reduced significantly after significant head injury. The central tenet of this theory is that people commit crimes for gratification. And crime results from criminal opportunity and from low self-control. Self-control is established in the early years of life through parenting. People with poor self-control are often risk takers, short-sighted, non-verbal, impulsive, insensitive, likely to have relationship problems, and to misuse substances. So if you took these 2 bullet points and substituted head injury for poor self-control, that would fit. That's what people with significant head injury can be like. Criminal behaviour is seen as part of a life pathway that's more likely in people with poor self-control. So is head injury a risk factor for crime? We know that social economic deprivation is a risk factor for head injury and for involvement in crime. It doesn't mean necessarily that head injury is a risk factor for crime. Could be that socioeconomic deprivation is a risk factor for ingrown toenails, but it doesn't mean ingrown toenails are a risk factor for crime. So what do studies on people with criminal convictions and demographically matched comparison group from the general population tell us? We try and control for environment and background. So we did a census of everyone in prison in Scotland, and we data linked that to electronic medical health records, pulled out the records for head injury. And so what we're really trying to get there was the lifetime prevalence of hospitalized head injury. And we took 3 people from the general population and matched them to the head injury population for age, gender, and for social deprivation. And so the prisoners were at greater risk of being hospitalized with head injury, intracranial injury, repeated hospitalization with head injury, and head injury before the age of 20. So hospitalization with head injury is more common, it occurs more often, and it's more severe in prisoners than in a matched general population comparison group. Now, what about birth control studies? Now, Hugh was mentioning this. I'll tell you a bit more about it. This is the birth cohort study in Sweden. And here they took electronic data registers of the birth cohort of everyone born within a period of time, and they linked that to criminal record histories and health histories. And then they matched each head injury case with 10 people from the general population and adjusted for socio-demographic factors. So trying to control for these environmental factors, and compared siblings with and without a head injury to give you a further control for the environment. You'd imagine siblings being brought up in a similar environment, and to some extent perhaps for genetics, if that is something you're interested in. So the risk of violent crime is 3 times higher in the head injury group. And if you compared siblings, it was still 2 times higher. The Australian cohort in Western Australia, a similar study, again, looking at a population, birth register population, and looking at registers of criminal convictions and pulling out people with head injury, comparing them with the general population, and with the same findings, that head injury is a risk factor for being involved in crime, and if you're a sibling with head injury, you're more likely to be involved in crime than if you're a sibling without. So people coming from similar backgrounds are more likely to be involved in crime if they've had a head injury. How common is a history of head injury in prisoners? Now, meta-analyses suggest 45 to 60% of prisoners have a history of head injury. The range in these studies are meta-analyses, it's wide, from 10 to 100%. And many of the studies don't make clear if their sample is representative of the population that they're coming from, which is very important. And they don't necessarily use validated tools to assess this lifetime history of traumatic brain injury. But I think you can take from the overall, the prevalence of head injury is high in prisoners. You know, we've been carrying out a programme of work in Scotland and in partnership with the Scottish Government the Scottish Health and Custody Network and with NHS Education Scotland. And it started off with some seminars in Holyrood, a presentation of the Justice Committee, Cabinet Secretary for Justice asked for a working paper, a working group produced that, and then since then I've been working through the recommendations. So let's look at a few aspects of study design and some of the outcomes of the studies we've done. So we've done quite a few studies, and I'm going to talk a little bit about 3 of them now. And these are separate studies on males, females, and young people in prison. We've altogether assessed perhaps 500. And the samples that we looked at were representative of the Scottish prison population. And we used validated tools to assess lifetime history of head injury, the Ohio State University TBI assessment method, validated in general population and in prison population. And we looked at disability, looking at the Glasgow Outcome at Discharge Scale, which is a scale for looking at disability after head injury in people who are not in the community. Both of these tools allow questioning and discussion with the participant, and that improves the validity of the responses. You can check what people are meaning, you can try and find out a bit more information about it. It helps put a bit more meat on the bones of the data that you have. So we defined significant head injury as head injury and loss of consciousness, or head injury with symptoms and no loss of consciousness on 2 or more occasions. The characteristics of all of these groups that are in common would be the high prevalence of significant head injury. Now, we find consistently in 80% of the prison population. Assault is the most common cause. In the general population in the UK, the most common cause is a fall, so that's different. Prevalence is higher. Repeated head injury is characteristic of this population, having many head injuries, often over long periods of time. Again, that's different from the average person you might see in the NHS who's had a head injury. Mental health and substance use problems, very common. So I'm going to tell you, focus a little bit on the study that we did in young people in prison. In Scotland, young people may be put in a Young Offenders Institute if aged 18 to 21. Now, when we did the study, it was 16 to 21. It's only just very recently gone up to 18. There's nobody in the prison in Scotland now aged under 18. And most of them would go to Parliaments, and pictures of it there's quite a, in some ways, quite a pleasant, relaxing environment. It's a modern prison, unfortunately, unlike many of the other prisons in Scotland. At the time of our study, there was about 350 young people were in prison. About 50 of them were women. And we looked at the representative sample of about 1/3 of the young males in Parliament. The mean age was 19. Disproportionate number came from the most deprived socioeconomic quintile. And although the median years of education was 10, you might think, well, is that too bad for a population from deprived background? But most had missed school through weekly truanting, exclusion, and many had special schooling and support needs. So although they were enrolled at school for many years, they weren't necessarily attending school. And we didn't include females because the sample would have been too small. So head injury is very common in young males in a Young Offenders Institute. It's usually mild, but repeated many times, and most often resulted from violence. So got to some of the data. Young people fighting an assault, 80% of the young people had a head injury. 3/4 had this history of repeated head injury with a median duration of 4 years, often caused by gang and scheme fighting. Mostly mild, a small number had moderate severe head injury. Very unusual to find somebody with only one head injury that was more severe and not to have had other head injuries. Trauma history was high, 55% had more than 3 ACEs. Almost 1/3 had PTSD. So some other important findings. There were indications that young males with significant head injury had greater difficulty with self-control. They self-reported on the self-report scores in the DEX were higher than those who didn't have significant head injury. Head injury from violence was 4 times higher in the sample of young males than you'd expect in the general population of young males. Almost 80% said they had not attended hospital after head injury. This is quite characteristic of people who are in the criminal justice system and have had head injury. They often do not go to hospital. So you don't get any information about head injury. You don't know about head injury. You don't usually think it's very important. We'll pick this up later. So here are some, I asked the research workers who are interviewing them for some overviews about young people. So they didn't independently recognize that they had a head injury history from gang fighting, and hadn't considered head injury as part of their ongoing needs. It's why important to have the semi-structured interview. You can question the people about different causes of head injury. By doing that, they say, oh yeah, I did have it through fighting, but I didn't think that was a head injury. Even when there was a loss of consciousness, they didn't quite understand what impact that might have. We look now at comparisons between adult males, adult females, and young males. You see the high prevalence in all of these groups. You see repeat head injury, very common in all of the groups. Early age at first head injury. Moderate to severe head injury being relatively common in the adults, but less common in the young adults. We'll come back to that. Disability being caused by significant head injury, being relatively common in the adults, less so in the young adults. We'll come back to that. Performance and cognitive tests didn't differ between people with significant head injury and those without in any of the groups. Overall, their cognitive performance was poorer than you'd expect from the general population. But there was, I can talk more about that if you want, but overall there wasn't a difference. Other studies have found similar. People with significant head injury were younger at their first offence, all of the subgroups. Violent convictions were more common in the adults. They were very common in the young adults with significant head injury, but not different from those without significant head injury. And this may be an issue to do with sentencing, reasons why people end up in prison differing slightly from between adults and young adults. So just to mention disability outcome. So what am I really talking about there? So this is moderate disability on this scale. And it means people are disabled, but they're independent for day-to-day functioning. Employment may be restricted for them. And often there are difficulties with social interactions. And when we explored this, given this was a semi-structured interview, it allowed us to do that, what people said is in almost all social spheres, they feel disabled. And this associated often with stress, feelings of stress. And with males, in addition, they would often talk about poor anger control being very disabling for them. Now, when I started off the introductions talking about multiple health morbidity, and say, well, why aren't you talking about that yet? Well, let's talk about it now. What you'll see here is these very high percentages of other health-related problems. And across all of these subgroups. The asterisks in red are where they were more common in those with significant head injuries than in those without. So multiple morbidity is very common, but in a number of these categories, it's more common in those with significant head injury. So we've got their substance use, mental health problems generally, any problem, clinical anxiety, clinical depression, abuse history, and PTSD. In women, in addition, chronic physical health is very common. It's something like 90% of women in prison have physical health problems. just going back to the young people again, are young people at a crossroads if they've had a head injury? Now, we know that the brain continues to develop through adolescence, and in particular the frontal lobes. And we know that more primitive parts of the brain, subcortical structures, advance more rapidly, they develop more quickly. And we know that young people generally tend to be more impulsive and to take risks. There's concerns really that this effect is enhanced in people who have got a history of head injury early in life. And when they get to a point when they're maturing in adolescence, they have greater difficulty in dealing with the complexities of social life and the demands that it makes. And so we've got brain injury reducing self-control, increasing risk-taking, making this worse, and potentially having an impact on them at this crossroads. Now, others have been interested in the development of people as persistent criminals and see late adolescence as a time point where often people desist and they kind of follow a different life path, and others persist and become life course criminals. And really, studies referred to there have looked at head injury and find that head injury really is a risk factor for people becoming life course criminals. So what are the implications for services? Future risks for young males in relation to crime and further head injury. We know they're having repeated head injury, they're going back to the same environment, they'll have more. Risk of acquiring more severe head injury history and disability as adult males. Well, that's what you find in adult males. So you might expect that the youth will acquire this if they continue along the same path. A need for education in people in prison with significant head injury. So I'm now just going to talk a bit about adult women in prison. I'll talk about women in trauma. History of trauma is very high in women in prison. You can see there in the first column, causes of trauma, the prevalence in the next column is very high. Age at onset, very young for child-based trauma, and in adolescence, in late adolescence, in adult trauma. Duration of the events these people are exposed to, very long. Take domestic abuse, needing of 7 years. Some people saying they've had multiple episodes of that. We look then at the occurrence of head injury during these episodes. More often than not, people are being knocked about the head during these long periods of time. Look again at domestic abuse. Almost 80% of women will have been knocked about the head in these periods, maybe of 7 years when they were suffering domestic abuse. Some views from research workers about women in prison. Physical abuse really had just been part of their lives. It was just normal. They didn't know that you could ask for help. And even just taking part in the study gave them insight to reflect on how the head injury might have affected them. They really didn't have information about head injury. Very quickly about older adults. We're doing studies now, we haven't really done studies on older adults and head injury, but the number of prisoners aged over 50 has doubled in the past decade. You can see there in the graph, the top graph, people aged over 60 and over, how that has increased over time. And generally, the population generally is aging and sentence length has been increasing. And the concern over mild cognitive impairment in older adults, the ability of prisoners to meet their support needs. A couple of studies in America showing 35 to 78% of people aged 50 and over having mild cognitive impairment. And really a question in our minds about relationships between this history of repeat head injury over long periods of time and the development chronic traumatic encephalopathy or other dementing conditions. There are also issues really about people transitioning at older age back into the community, potentially with cognitive impairment. So let's take some perspectives on the wave as we begin to get to the end of the talk. Head injury and other health problems are interwoven. You're finding people with head injury and many other health problems in people in prison. And they're coming from challenging backgrounds. There's a need for a holistic intervention and management and support plans in custody that take account of this and don't just pull out one of the strands in the weave, but really take account of the weave if we're really wanting to do something about it. It requires interagency work, communication between steps and the person journeying through the criminal justice system, which we don't have. And to bear in mind differences in risk and health problems in men, women, and young people, and not just seeing them as all being the same, one size will not fit all. So when we're thinking about ways forward, there are a number of pressures in the criminal justice system. In prisons, the top priority really is to keep people safe and cover their basic health needs. We need to try somehow to get routine assessments and service pathways established. We need to incorporate head injury as a risk factor in intervention plans, train staff, and help prisoners to develop knowledge about head injury. So there need to be assessments at these different steps in the criminal justice process using simple validated tools. I think in Scotland, we've made progress with recognition of the issue and the training needs of staff, but not in terms of preventing loss of information through the system or developing resources. So these are some of the places we need to go next. So staff training, prisoner education, effective and practical interventions. There's very little evidence for effective interventions, and research into practice. And this paper of Flora Matheson was looking particularly at young people and women, and really recommending research into practice. We're doing research into models and doing research into practice and focusing on that more now than trying to understand the nature of head injury in prisoners. So we've done some studies looking at what staff know about head injury, and they tend to have deficits in knowledge about the acute effects of head injury. There will be people going to prison on remand or coming from hospital and PTA. They don't understand about that. Insight into issues after head injury, staff tend not to understand that people with a head injury will not know about the impact of it. They won't have insight into that. And the need for training and assessment and management is what they asked for in the surveys that we did. So we have now in the UK and more recently in Scotland, the vulnerability risk assessment in police custody, which everyone goes through a question on head injury. The police ask that, and then they can make some notes. The information isn't necessarily passed on though, so we want to do something about that. And we'll have a question in prison reception, which we're revising prison reception assessments. We're waiting for that to happen about head injury. We're doing quite a bit in staff training here. I've been working on modules with NHS Education Scotland to be e-modules available in TURAS, free, and go through quite a bit of detail about head injury in the criminal justice system, 4 modules, and they'll be available to social work, because they may want their own module to do that for them. We've got something in custody staff training, and I've given a number of webinars to anyone who's foolish enough to ask me to do one. Scottish Prison Service are going to have a very short module, and hopefully also police staff. So 2 things I'm just going to mention very quickly in 1 minute. We have done a study in prisoner education. It's just really to reinforce to you that this is quite easy to do. One 1-hour session of education to groups of prisoners about head injury changes knowledge across the session and at 4-week follow-up. And we've got plans to introduce this into Scottish prisons. So in terms of the weave of multiple morbidity, you can understand, I hope, a bit more now about the life challenges that people will have had when they become involved in the criminal justice system, about the multiple health morbidities that they have, and that head injury is one of them and is part of this weave. And we need to encourage colleagues to incorporate an understanding about head injury and other things that they're teaching about, whether it's trauma-based practice or substance misuse. They should be talking also about head injury. So I'm just going to leave you finally with this thought.